Hi, this is Professor Colleen Parsons again. This is Lecture 3B, General Assessment. And in this video, we'll be going over pain assessment and the rest of the skills for a physical assessment, the basic skills for the physical assessment. Now, in the PowerPoint slides, there is a whole middle part about vital signs that I'm not including because you're getting them somewhere else in foundations. So we won't include them in our lecture, but we can go over them in class. And if you have any questions, please ask me. You do have access to the slides in the PowerPoint. So as you know, pain is the fifth vital sign, and I'm pretty sure you'll be going over this in foundations as well. However, this is such an important part of assessment, health assessment, that I want to review it here. With the Universal Pain Assessment tool, we are talking about going from 0 to 10. So you say something to your patient like, I'm sure you've been asked this before, do you have any pain? Yes. On a scale from 0 to 10, if 10 is the worst possible pain, what would you rate your pain? And an awful lot of patients will rate it as 10. They don't really see the middle numbers, especially if they're in any sort of pain at all. So what I want you to remember to do is to give them a visual for the worst possible pain you can imagine. And one of the nurses over in labor and delivery taught me, as if a bear were mauling you, and that's a 10. That's pretty bad pain. If you'd want that limb cut off, that's a pretty bad. So if you have a leg pain, it's so bad you just would want it to be cut off. That's the kind of pain we're talking about for number 10. Then patients are less apt to give you a 10, and using the scale appropriately really helps us medicate them appropriately. Here's sort of a funny one, worst possible pain, and that's really what it looks like. Their face will look happy and mostly happy. So for me, I usually hang around 3, 4, 5 pain. There are some days it gets quite a bit worse than that, but 3, 4 most days. So I might not have this kind of face because my pain is so chronic, I can deal with it. Sorry, these words are a little bit blurry there. And then here's a very funny one. But that's kind of what it feels like. You would just want the pain to end at any cost. So you're getting the idea. This isn't a pain scale I would show a patient. I'm just showing you. So there are different types of pain, acute pain and chronic pain. Chronic pain has with it chronic malignant pain, which has to do with cancer, and chronic non-malignant pain, which has to do with non-cancerous types of chronic pain, like my knees, for example, arthritis. Subjective pain is what the patient says it is. And if the patient says they're in pain, they're in pain. It doesn't matter whether they are a drug abuser or not. We still need to medicate them. We just will not use narcotics for them. Some people are much more sensitive to pain than others, and that's just how it is. So pain is always subjective because we can't prove that somebody's in pain. You can watch their nonverbals, but there's nothing that we have that actually measures pain very well. So it is whatever the patient is saying it is. Actually, pain occurs on a neurochemical level, and you can't see it. So initial pain assessment, these are really good questions. Begin to learn how to practice them. Where is your pain? When did your pain start? What does your pain feel like? And then really getting them to tell you. If they can't, especially a smaller child, what would you have to do to me to make me feel this way? that's going to give you a much more accurate picture. So if they say, my stomach hurts, yes, honey, I understand your stomach hurts. What would you have to do to me to make me feel like you do right now? Well, I'd have to poke you with a knife, or I'd have to punch you in the stomach. That gives you a more clear idea of how much pain they're in, or the quality of their pain, I guess. What makes your pain feel better or worse? Does your pain limit how you function? How do you usually behave when you're in this kind of pain? Now me, I just want to go into a quiet room and just stay there until my medication kicks in. Now sometimes if it's a chronic pain, like with my knees, I just continue, or a migraine, I just continue to go through my life because I know that it's there, it's not getting any worse, it's just there. But if I were to have a new kind of pain, more of an acute pain, I'm going to go into my bedroom. Other people might cry, other people demand to go to the emergency room. We can't predict that, and it could be different for different people. What does this pain mean to you, and why do you think you're having the pain? Sometimes patients know, and sometimes they guess wrong, and sometimes they've been looking through the internet and think they're dying. Every facility that you work in will have a different sort of pain assessment. Here's just one example. And here's a sample pain note. And I'm not going to stay with this for very long, but you can see that it includes everything that we've been just talking about, and you can read it at your leisure, and we'll probably go over it in class. Determine what you need to do with regard to finishing your physical assessment. So you're going to gather your equipment and all of the things that you need. Here's everything that you need. We will not, in any of our physical assessments in the health assessment course, be taking vital signs. We've sent that over to Foundations, and that's where they do that. We also won't be using a speculum or anything like that. So standard precautions are always embraced. So you're going to wash your hands, and even when you are doing your skills assessments for health assessment, you're going to squirt your hands with hand sanitizer. You will have no need to wear gloves unless somebody has something oozing out of them. And you're going to go to your patient with clean equipment. That includes wiping off your stethoscope. So cultivating your senses, inspection, palpation, percussion, and auscultation are all things that you do, but you will also use your sense of smell, touch, hearing. You're really going to listen to the patient as well as watch what they're doing. You're going to be touching their skin. You're going to smell and assess for odors. So as we talked about in lecture 3A, you are going to inspect each aspect before you do any of your proceed with any of your skills assessments, your focused assessments. You will do inspection as the first thing, and you'll see that actually on the skills assessment. So you want reasonably good lighting. You want to have practiced this many times so that you know what you're getting into. Palpation, which means touching the patient. So you're going to be touching the patient, feeling for texture, temperature, moisture. This is specifically relating to the hair, the skin. And as we progress through the skills assessments, you're going to be pressing into their aspects of their skin, feeling their lymph nodes, feeling their organs. You can do a light palpation or a deep palpation depending on the level of assessment that you're doing. You will always be looking for lumps and bumps, and you're going to be asking the patient, anytime you do a palpation, let me know if you feel any sense of tenderness or pain as I press on you here. You'll be using your fingertips, and we'll go over this in more detail when we actually do palpation. But you're going to use your fingertips or sometimes your fingers and thumbs, depending on what it is you're feeling for. You will start always with light palpation, and then you go to deeper palpation when needed. You're not going to do any palpation that's going so deep that it will cause internal injury or pain. Sometimes you'll need to do bimanual palpation, which means you're going to be using two hands, sometimes one underneath the body and then pressing on top of the body as well. Percussion means a type of tapping on the patient. There are different ways to do it, and we'll experiment in class. Pretty much this is what I do. I put my finger there and I tap. Some people will do 3 fingers and tap, but you're tapping with your middle finger and you're looking for different tones, and it's kind of a different feel. I more feel it in my finger than I actually hear it with my ears, but we'll practice and you'll get used to it. You'll be practicing on yourself and practicing on other people. So there's both direct and indirect percussion. Hoping that's what I said before. And auscultation. Auscultation is actually using your stethoscope to hear what's happening. There are 2 parts of your stethoscope. The flat part, oh, I don't have my stethoscope here, sorry. So the flat part is either the drum or the diaphragm, and then the curvy part is called the bell. And it depends on what you're listening for, which part of the stethoscope you use. So we'll be experimenting with that as well. So we're going to practice just like we did before last week. So in lab time, we're going to practice with somebody as the observer, somebody as the nurse, and somebody as the patient. Now, when it's your turn to be the observer, please, it is in the teaching that we do the most learning. So as the observer, you need to be able to tell the nurse, did she do that correctly? Did he or she do that correctly? So when she or he put the stethoscope, this is for further lessons, but here on the heart, was it supposed to be here or here, depending on how you named the body part. And that's all we have. Okay, thank you very much.